So, right. So in normal physiology, in resting conditions, we have a negative, we have a difference pressure in between the alveoli pressure and the chest wall pressure of around 4 millimeters of mercury. This is what we call the transpulmonary pressure, the difference between the alveolar pressure and the pleural pressure. Okay. Go here. Right. So if we put these two forces together, okay, in a graph, okay, you have in pink on the left-hand side, you have the pressure exerted by the elastic recoil of the chest wall, okay, which tends to expand the whole system, so negative, creating a negative pressure inside our thorax. And then on the right-hand side, okay, in blue, the pressure exerted by the elastic recoil of the lung, which is positive because it tends to collapse the alveoli and the whole lung. Okay, if we put those lines together, then this red continuous line is created. Okay, and this is both the behavior of the whole system. Okay, in inspiration. Okay, so when we are applying some transmural pressure and we are increasing the transmural pressure, we are opening up the lungs. Okay, if we do the other way around, if we reduce the transmural pressure, then the vital capacity of the lung, it reduces, okay, and it can collapse the alveoli. Okay, in resting conditions, okay, at the level of what we call functional residual capacity, the pressure of the whole system is 0. Okay, however, if the whole pressure is 0, we would be probably dead because all our alveoli would be completely collapsed. What we have is a very clever system and substance that is called surfactant that keep our alveoli open. Okay, and that is at 4 centimeters of water. So at 4 centimeters of water, we have a little bit of our lung open. Okay, and that's always above functional residual capacity. Is it clear? Any questions so far?
Right. I'm looking up for questions on the group and there isn't any. It's very clear. Thank you.
So, you know this concept. This concept is taught in uni, in med school. So we know that the behavior of the respiratory system is different between inspiration and expiration, and this different behavior is called hysteresis. So we have this lower part of the curve, okay, which is in inspiration, okay, and then the return in purple is the behavior of the respiratory system in expiration, okay? And as you can see, at any given change of transmural pressure, we will have a increase in lung volume. And depending on where are we on the curve, we will have a much higher increment of lung volume or another, okay? So let's have a look a bit more at this curve. Again, the lower line is the line in inspiration. The higher line on the top is the behavior in expiration. So we have two different points here, the lower inflection point and the upper inflection point, which are the most important ones. Okay, if we have a look at the lower inflection point, this is, if you take the example of a balloon, this is the minimum pressure required to keep the alveoli, all the alveoli open and recruited. Okay, if you take the example of a balloon, you know that at the very beginning there is a huge resistance to inflate the balloon, but as soon as you reach a certain point, then it becomes really easy to inflate the balloon. So this is the lower inflection point. Okay, so below that point, all the alveoli are not recruited, or most of them are not recruited. Okay, and they are pretty much collapsed. And in order to open up these alveoli, we need to apply a lot of pressure, as you can see from the curve. Okay, so in this graph, the PEEP is pointed at the very left-hand side. I would put the PEEP a bit towards more to the right. So what we need is to, if we are invasively ventilating those children, ventilate them with an optimal PEEP to keep most of the alveoli open, okay? And if we do it towards the right-hand side, we are going to optimize this recruitment, okay? So the other important part of this graph is the upper inflection point, okay? Beyond that point, we are over distending the lungs, okay? And just to make an example, you can see this boy, if we keep putting pressure to open up the lungs, there will be a chance, a very high chance of causing an pneumothorax, okay? Right, another important concept is the closing volume or the closing capacity. Okay, so the closing capacity is the lung volume at which the small airways collapse completely. Okay, and as you can see from the graph, okay, if we go down the graph at the far end, okay, this is the closing volume. In this situation, all the airways and all the small bronchi without cartilage, they collapse, okay, and it causes atelectasis, okay, and this can cause eventually, if we have atelectasis all over the lung, it can cause respiratory failure, okay. So we always need to make sure that we are ventilating children above the closing volume, above or beyond the closing capacity, to avoid the atelectasis of these small airways. In adults, is quite easy. So all of us, our closing capacity is well within the expiratory reserve volume, so within the functional residual capacity. So when we are breathing at tidal volume, we are far away from the closing capacity. But small children, especially neonates, you can see on the left-hand side the closing capacity. The closing capacity is within the tidal volumes. Okay, so the way a sick neonate or a sick child compensates this is by having a reflex, which what they do is close their glottis, their vocal cords, okay, in expiration. So what they will do is they are generating an expiratory pressure, like an autogenerated PIP, okay, so they can keep their airways open. And when they are doing so, you will see those children in ED or in ICU grunting. So the grunting is the mechanism that small children and neonates, when they are sick, okay, is the mechanism for them to avoid closing capacity at tidal volume. Right. We've talked about compliance and static properties. Let's talk about dynamic properties, which is basically resistant. So resistant, we usually relate the resistance to the airways. So the trachea and the main bronchi and then the peripheral alveoli. But as you can see from this table, there are all other components of the respiratory system that are involved in resistance, okay? So not everything is trachea, bronchi, and peripheral bronchi, but also lung tissue, chest wall, they also offer some sort of resistance, okay? And that's what we need to overcome when we are ventilating children. So at that point of the presentation, what would be the difference between a spontaneous ventilation or a spontaneous breath and a mechanical breath? I would say it's easy to understand. So the most important difference is that a spontaneous breath is a negative pressure breath, whereas the mechanical breath is most of them some positive pressure breath. Okay, there are some exceptions. Okay, but this would be the main difference. Okay, so as you can see there on the right-hand side from the graphs, when we are self-ventilating, we are applying a negative pressure. So by forcing our diaphragm to go down, we are increasing the negative pressure of the pleural cavity. That will create a much higher difference between the pleural space and the chest wall, and by doing so, the transpulmonary pressure will increase, and we will generate an increase in volume. Okay, that is what you can see from the graphs. And when we are doing a positive pressure ventilation or a positive pressure breath, instead of applying negative pressure, we are applying positive pressure. So we are applying positive pressure to the alveoli. By doing so, the pleural space will become positive, so the pleural pressure will be positive, but the amount of alveolar pressure and the amount of chest wall pressure will be again high. So the difference is what will generate a movement of the alveoli towards inflation. Okay. So basically, it's all we need is a change in transpulmonary pressure, whether it's created or is generated by a negative pressure breath or by a positive pressure breath. Okay, and always remember that the expiration is always a passive mechanism. We can't do anything from an expiration point of view. It's all done by the patient. So these are my take-home messages so far. Okay, the lungs only will change in volume when there is a change in transpulmonary pressure. Compliance, remember, is optimal above functional residual capacity. And so please, if you are ventilating a child while the retrieval team is coming, use optimal PEEP. Okay, and we will talk about what's the optimal PEEP depending on the situation. We know the compliance is poor at a very low tidal volumes or very low lung volumes, but also at very high lung volumes. Okay, so we need to ventilate children in the window of perfect compliance. Okay, resistance is not applied to the airways, and we said that the expiration is a passive mechanism. So what are the basic methods for ventilatory support in children? So we have non-invasive ventilation, which is the continuous positive airway pressure, CPAP, or the bi-level pressure, which is a pressure in inspiration and a pressure in expiration. So EPAP and EPAP, sorry, IPAP and EPAP, which is called sometimes BiPAP. Okay, and then we have invasive mechanical ventilation, which we have conventional modes, which I will talk about a bit more, and I will go very quickly through two of the non-conventional modes. Okay, remember that OptiFlow, high flow nasal cannula, is not a form of ventilatory support. Okay, it's just a form of oxygen therapy. Okay, that's very important to remember. Right, just a quick overlook of which are the machines that you might be familiar with. Probably you are not familiar with the ones on the left-hand side. They're very old anesthetic machines that you can see in the Science Museum in London. At the moment, we use the more modern anesthetic machines. We have the non-invasive ventilation at home machines, which are the ones on the right top corner. We have on the lower side the transport ventilators, and the baby pack on the left-hand side, and the Hamilton on the right-hand side, which is the ventilator that we use in Panda. And this is the most common ventilator used for most of the retrieval teams. And then on the right, on the far right-hand side, we have the PICU ventilators. So all the ventilators pretty much, they have this sort of diagram of the structure. So you have the device, a ventilator that applies a flow and pressure depending on the mode. Okay, then you will have a humidifier to make sure that the air that you are providing and the oxygen is moist. Okay, then you provide this flow and pressure through nasotracheal tube or orotracheal tube, or you can apply it through face masks if we are talking about non-invasive ventilation. Okay, then we will have an expiratory port, okay, which we will use to detect the end-tidal CO2, okay, and that's to detect how much CO2 is the patient generating, okay, and we can monitor that with this piece of equipment. And the graph on the right-hand side is the end-tidal CO2 diagram. And then we have the ventilator, okay, which will give you this sort of graphs, okay. At the top you have the pressure time, in the middle you have flow time, and at the end you have volume time. And this is how we monitor how well are we ventilating children, okay. Some ventilators, they do have different curves, but most of them, they do have these three main curves. So what are the goals in mechanical ventilation? So first of all, we want to improve ventilation by increasing the respiratory rate and the tidal volume, and this is important. So if you are dealing with a child that has problems with ventilation, so basically problems eliminating CO2, what you need to do is increase the respiratory rate and increase the tidal volume. If the child is in non-invasive ventilation, you will not be able to increase the rate, but you might support his breathing a bit more to increase the tidal volume, okay? And we want to do this to correct the respiratory acidosis or to assist the child if the child has any neurological or muscle dysfunction, okay? We want to correct hypoxemia if we have problems with oxygenation, and the way we do that is by increasing the FiO2 or by increasing the PIP. We talk about ventilating children with optimal PIP, and that's the whole point. We want to optimize the lung recruitment to make sure that all the alveoli are participating in gas exchange. And then the last function when we are ventilating children is to improve the cardiac function, okay? And this is what we call cardiopulmonary interaction. And this is not the session to talk, but if you are interested, there are a lot of books and papers talking about cardiopulmonary interaction. So when we are mechanically ventilating children using positive pressure ventilation, we decrease the preload because we are applying a positive pressure inside of the thorax. So we are impairing the return of the venous blood towards the right atrium. We have a reduction in afterload, and we are decreasing the metabolic demand because what we are doing basically is we let all the respiratory muscles to take a break and rest. Okay. So this is what we want to achieve. We want to achieve tidal volume 6 to 8 ml per kilo of ideal body weight, and I will talk where is this 6 to 8 ml per kilo coming from. We want to achieve saturation above 88 or 92% in most of children, except unless there is any specific condition that contraindicates higher saturation. We want to make sure that we are ventilating children using as less oxygen as possible, so ideally less than 60% oxygen. We want to achieve plateau pressures less than 30 centimeters of water. And just to let you know, when everyone is talking about plateau pressure, this is the pressure in the alveoli. So if we go beyond 30 centimeters of water persistently, there is a very high chance that we can cause a pneumothorax. And then what is the CO2 that we are aiming for depends on the condition that we are talking about. So this is the same graph that we have seen before. And this is the study in Nature that show what's the ideal tidal volume ratio weight in every mammal, okay? And as you can see, every mammal has a lung volume ratio of 6.5. So 6.3, 6.5 ml per kilo of ideal body weight is the tidal volume, okay, of every mammal in the world, okay? From the small bats or mouse to the big or giant whales. So, as I said, depending on which condition we are ventilating, we will aim for different settings. So the standard patient, the one with no lung pathology or no cardiac pathology, we will be aiming for inspiratory pressures 15 to 30, ideally less than 30. Ventilate always with a PIP of 5 or above that, okay, if we need to, and we are aiming for an entitled CO2 of around 4 to 6 kilopascals and saturations above 95%, unless there is any contraindication for that. In asthmatic patients, and we will talk about this type 2 respiratory failure, okay, but I'm advancing that. Asthma is a type 2 respiratory failure. We want to use inspiratory pressures that allows us to move the chest, basically. We will use lower PIP because these patients, they do have auto PIP, okay? We will aim for permissive hypercapnia, which means that we will aim for higher end-tidal CO2s, and we will aim for saturations above 90%. In ARDS, the typical type 1 respiratory failure, ideally peak pressures to move the chest, PIP usually above 5, well above 5, sometimes even 15 or 20. Again, a permissive hypercapnic approach, okay, higher CO2 and saturation sometimes even lower, like more than 85%. We cannot use this permissive hypercapnic approach in patients with traumatic brain injury, Okay, this sort of approach is contraindicated in traumatic brain injury or any patient with raised ICP. Okay, this permissive hypercapnic approach is the one that we use for asthma and ARDS because it avoids dynamic hyperinflation, so auto-PIP, and it avoids paratrauma, and it avoids the ventilator-associated injury. So it's a sort of protective lung strategy. So lower tidal volumes at a higher rate and enough pressure to keep the whole lung open, okay, especially in ARDS, okay. So when the patient is on the ventilator, these are the main principles that you will need to take into account. So make sure that you have adequate ventilation, okay, and you don't have any problems in any part of your circuit, okay, whether you are using an ICU ventilator or a theater ventilator, okay. Use optimal PIP to avoid atelectasis. You need to monitor the entitled CO2 and saturations continuously. So if you ask me which are the two mandatory parameters, Tidal and SATs are the mandatory parameters when we are ventilating children. And if there is any acute problem or sudden problem with ventilation or oxygenation, make sure that you are excluding any problems from the circuit to the patient. Okay, and you can use the acronym of DOPES. So make sure that the AT tube is not displaced. Make sure that there is no obstruction in the AT tube or any part of the circuit. No one is, have his foot obstructing any of the circuit limbs. Make sure that there is no pneumothorax. Make sure that your equipment is all working. Okay, so if your saturations are poor, make sure that the SAT probe is working properly. Okay, and the last thing is make sure that you have decompressed your stomach. What are the phases of a mechanical breath? We have 4 phases. So the phase 1 is the initiation phase, the trigger. Okay, who starts the inspiratory phase? Can be the ventilator, but can also be the patient. The inspiratory phase, which is controlled by the limit variable, and this is where it comes the different mode of ventilation, whether we are using pressure or we are using volume. Okay. The cycling phase is who ends the inspiratory phase. Again, is the patient who is cycling from inspiration to expiration, or if it's the ventilator who is doing that. And then the expiratory phase, which, as I said before, it's going to be governed by the patient, and it's governed by how much PIP are we achieving. Okay, we can't do anything else than providing an end of the expiration positive pressure. Okay. So if we are going through no support to a lot of support when we are on mechanical ventilation, we have the control breaths where the patient does no work whatsoever. So the ventilator provides all the work. We can assist the breath. So the patient triggers the ventilation. The ventilator detects that there is a breath initiated and then assists that breath. And then the supported breath. So the patient triggers the ventilation. The ventilator detects that breath. The patient is doing a little bit of effort, okay, or most of the effort, but the ventilator just supports that breath, okay. So this is how it looks like in a ventilation curve. So you have the assist control ventilation, which depending on the patient effort, some breaths will be assisted or not. For example, there is no patient effort in this one, so no assist. In these 2 ones, the patient is doing an effort. You can see a small deflection here. So the patient is doing an effort to breathe. The ventilator detects that and triggers a breath. Okay. And then we have the synchronized intermittent mandatory ventilation, where we have the mandatory breaths and the spontaneous breaths. So the patient is allowed to breathe in between the mandatory breaths. Okay. On top of this synchronized intermittent mandatory ventilation, you can support this spontaneous breath by providing pressure support. And this is how it looks like. Okay, so you are providing some assistance, okay, in this breath. So there is some deflection. The patient is always breathing, triggering the breath. Okay, and there are some breaths that the ventilator is totally supporting. Okay, and that's why the volume is slightly different between breaths. Okay. And then we have two basic modes of ventilation. We can ventilate by pressure or we can ventilate by volume. Okay, if we ventilate by pressure, okay, we are using a decreasing flow wave. Our pressure the whole time is constant, but the volume is variable. This means that if we are keeping the pressure constant, depending on how compliant is the lung at each time, the volume within the lungs will be a bit different. Okay, so there is a risk of trauma within this mode of ventilation. Okay, if the compliance is very high, okay, then at the same level of pressure, we can achieve very high volumes, and there is a risk of causing a pneumothorax. And on the other side, if the compliance is very low, at the same level of pressure, we will be achieving a very tiny amount of tidal volume. Okay. Then on the other side, we have the volume control ventilation. Okay, and you will see on the ventilator screen a continuous flow. It's a square shape. Okay, on the flow time curve. Okay, in this particular mode, the volume is constant, so the ventilator is going to send 205 mL of air inside the lungs, or 100 mL of air, whatever you have prescribed. Okay, and then depending on the compliance of the system, the pressure will be variable. Okay, and then in that particular mode, there is a risk of barotrauma. Okay, you are sending 200 mL of air inside the lungs of that patient, and if the lungs of that patient are very compliant, okay, you will cause you can cause also a pneumothorax by generating a lot of pressure. Okay, and then in the recent years, most of the ventilations have incorporated a software that combines these two modes. Okay, this is what we call the pressure regulated volume control. It uses a decreasing flow wave. Okay, the same as pressure control. So we have a decreasing flow wave kind of ventilator, but uses a constant volume. Okay, so it has the benefits of both modes. So we have the benefits of the pressure control ventilation and the benefits of the volume control ventilation. Okay, there is also a small risk of barotrauma, especially if you don't program your alarms properly. Okay, but it will allow you to program a constant volume and a maximum amount of pressure. Okay, and then beyond that pressure, the ventilator will alarm. So this is actually the mode that we use in Cambridge, and is a mode that is used in other centers, in other units. If you ask me which mode is better, pressure control or volume control, it's a bit difficult to ask that question. But if we look at patients with ARDS, there has been no difference in hospital mortality or no difference in ICU mortality in between, if you compare those modes. There is a slight benefit towards pressure control ventilation, okay, in this particular patient, okay, and that's why we use either pressure control ventilation, making sure that you are not over distending the lungs, or we use pressure regulated volume control. Okay, that's because we know that there is a slightly more positive outcome using pressure than using volume. Okay, how do we monitor a patient that is ventilated in ITU? So we need to look at the patient physically. So physical examination is key. So make sure that you have good bilateral entry, the chest is moving symmetric. Okay, then we have a lot of data that comes from the ventilator. Okay, and whether you are on a volume control mode or in pressure control mode. So if you are on volume, you need to make sure that your peak pressures are optimal and not beyond a certain limit. If you are on pressure control ventilation, make sure that your minute volume is optimal and you are not achieving a tidal volumes beyond a certain value. And make sure that if the patient is not completely sedated and muscle relaxed, so he is spontaneously breathing, you are supporting the breath appropriately. Okay, so you program a proper pressure support. Okay, and of course, make sure that you are providing a decent amount of oxygen. Okay, and then there is the section of monitoring. As I said, pulse oximetry and capnometry are mandatory. And then you can always have the help of the blood gases. If we look at different pictures of end-tidal CO2 trace, I would like to keep an eye on three. The first one, top left, this is what the end-tidal looks like when you have an esophageal intubation, okay? So if you have a end-tidal CO2 trace like this immediately following what you think is been a successful intubation, it's not, okay? That tube most probably is on the esophagus, so take it out and start again. The second one that I would like to mention is this one, the bronchospasm type. So this is what the end-tidal CO2 trace looks like in an asthmatic patient, okay? Or a viral indisposed child, okay? And then the third one is what we call the curare cleft, okay? You have this cleft, this deflection here. This is the patient trying to breathe on top of a mandatory breath provided by the ventilator. So if this is happening and you are preparing the child to be transferred to a CT scan or preparing the child to be transferred by a retrieval team, your child is not well sedated and is not well muscle relaxed, okay? So he's still breathing on top of the ventilator. And then, as I said, you have the help of the blood gases. So we have two different blood gases, the one on the left, okay? I wanted to show you a gas of a patient overventilated. So as you can see, you have a patient with a pH of 7.5, with a PO2 of 41 millimeters of mercury. So this patient is clearly overventilated, okay? The one on the right-hand side, you have a patient with a respiratory acidosis. As you can see, the pH is 7.18. The CO2 is 76 millimeters of mercury, which is close to 9 kilopascals in UK units. So he has a clear respiratory acidosis. So depending on which parameter you want to add, you need to change different settings. Okay, so if you have a patient with respiratory acidosis with problems with eliminating CO2, you need to increase the ventilation. You need to increase the minute volume by increasing the respiratory rate or by increasing the tidal volume if you are in volume control or PRVC. And you can increase the tidal volume, increasing the pressure, okay, if you are in pressure control ventilation. If you want to increase oxygenation because your patient is not well oxygenated, you have to increase the FiO2 and you have to increase your mean airway pressure, basically by increasing the PIP. Okay, there is a strategy of increasing the inspiratory time, okay, and that will increase your oxygenation as well, okay. Right, very quickly, two non-conventional modes of ventilation, high frequency oscillatory ventilation, which unless you are in an ICU, you will probably not come across. So this is what I call a wobbling CPAP, okay. Of a gas that is being provided towards the airways, okay. So that gas will provide a certain amount of mean airway pressure, and within this mean airway pressure, you are going to generate vibrations, okay. So you are ventilating with very small tidal volumes, okay, at a very high frequency, okay, and you are ventilating in this area of the hysteresis core, so in the safe window. Okay, so you are not allowing the lung to de-recruit, but you also are protecting the lung from over-distension. Okay. And then the second type of non-conventional mode is the negative pressure ventilation, which was very famous or very popular during the polio epidemic. But still used in certain conditions. Okay, so as you can see in this picture, this is a patient with bidirectional glen, which is a specific type of cardiac surgery that benefit from negative pressure ventilation. Okay, and what this child has is a cuirass that generates negative pressure inside the chest. Okay. Right. Before I went into which patients do we need to support, I wanted to show two clinical scenarios. So you have this 3-month-old ex-34-weeker admitted with clear signs of bronchiolitis. Okay, and you have this, so the child has been started on high flow nasal cannula, and you have these settings on the high flow nasal cannula. Okay, and you have the chest X-ray below. And then on the other side, you have this 9-month-old with previous upper respiratory tract infection symptoms for a week, and then he's been admitted recently with severe increased work of breathing, and these are the admission vitals. Okay, and he's clearly working hard, and this is his most recent venous gas. So I just wanted to think about everyone, which patient would you, from the very beginning, start invasive or mechanical ventilation, or what would be your strategy? Just think about, and we'll go through that. So when do we need to support the breathing of a child? So basically, with failure. So the definition of a good respiratory failure is when you have, a failure of your the whole respiratory system to provide a decent oxygenation and ventilation. Okay, depending on which parameter are we talking about, we will talk about type 1 respiratory failure or hypoxamic, or type 2 respiratory failure or hypercapnic. So when we have a hypoxamic respiratory failure, the definition is when we have an arterial pressure of oxygen below 60 millimeters of mercury or 8 kilopascals. And when we have a type 2 or hypercapnic respiratory failure, we will have a arterial pressure of carbon dioxide or more than 60 millimeters of mercury or more than 8-9 kilopascals. Okay, there are different mechanisms, okay, that explain these two type of failures. One is hypoventilation. The second one is the VQ mismatch, and the third one is an intra cardiac shunt or an extra cardiac shunt. So the hypoxamic or type 1 respiratory failure is defined by a PaO2 of less than 60 meters of mercury or less than 8 kilopascals. Okay, sorry, 1 second. The gas exchange in this condition is impaired at the level of the alveolar capillary membrane. Okay, and sometimes, or most of the times, the CO2 is usually normal. Okay, or just slightly elevated. Okay, on the other side, okay, you have the hypercapnic or type 2 respiratory failure, when you have a PCO2 of more than 60 millimeters of mercury, more than 8-9 kilopascals. Okay, in this particular type of patients, apart from a problem with ventilation, you have sometimes problem with the oxygenation, because remember that CO2 is 20 times more diffusible than oxygen. So if the elimination of the CO2 is impaired, most probably there will be an impairment of the gas exchange of the oxygen as well. Okay. So the mechanisms for let me go through each one of them first. So the type 1, the ventilation perfusion mismatch and the shunt are the two mechanisms, okay, that explain this type 1 or hypoxamic respiratory failure. Okay, and as you can see from the hemoglobin and the dissociation curve, whenever you have a arterial pressure of oxygen of less than 60 millimeters of mercury, your oxygen saturations measured by pulse oximetry will be 90% or lower. Okay, so that's an idea of how well oxygenated is your patient. As we said, the gas exchange in this particular condition is impaired at the level of the alveolar capillary membrane. Okay, so in this picture in the middle, you have an alveoli with a capillary, okay, and there is only a possibility for red cell to go through the capillary each time, and usually it takes a quarter of a second for a normal red cell, considering that the membrane is normal, to get fully oxygenated. Okay, so 0.25 seconds for a red cell to get all the oxygen from the alveoli. If we have an impairment of that membrane, because there is inflammation, there is a lot of cells in the interstitium, inflammatory cells, or there is a lot of extra-alveolar water or fluid, then the diffusion of the oxygen is impaired, and then the amount of time for the red cell to get all the oxygen is increased, and sometimes it's beyond 1 second. So the red cell will leave the alveoli without being fully saturated. There is a compensatory mechanism of the body when we have situations of ventilation perfusion mismatch, which is the hypoxic pulmonary vasoconstriction. This means that when we have areas of our lung that are not well ventilated, okay, in order to avoid the mismatch, the body, what it has is it will vasoconstrict the arteries and the capillaries that will go towards the areas that are not ventilated. Okay, and those areas that are well ventilated, there will be a compensation and there will be a vasodilatation. Okay, the goal is to try and minimize the mismatch. So these are the X-ray type pictures of a type 1 respiratory failure. Okay, on this side you will see a left-sided pneumonia. Okay, in this side you will see a acute lung injury or ARDS, bilateral infiltrates with no cardiomegaly, no other explanation for these infiltrates. Okay, on this side you will have a child with cardiomegaly, okay, and interstitial lung edema, which is pulmonary plethora. Okay, and then on this side you have a typical picture of a patient with interstitial lung disease with ground glass opacification everywhere. Okay, in all these types of in all these conditions, the oxygenation is impaired at the level of the alveolo-capillary membrane. Okay. In type 2 hypercapnic respiratory failure, the two main mechanisms that explain this failure is hypoventilation and increased dead space. So hypoventilation happens when you have a poor respiratory drive, or you have a severe weakness of your respiratory muscles, you have any neurologic conditions that allows you not to breathe appropriately. Okay, and then dead space occurs when you have a severe obstruction of your airways. These two mechanisms explains the type 2 hypercapnic respiratory failure. And these are the X-rays that you can see in these conditions. So on the first one, this one on the left-hand side, let me put the laser because it might be better. I don't know how to put the laser, sorry. So this first one, typical X-ray of a patient with asthma, very flat diaphragms, very flat ribs, and there is at least 10 intercostal spaces. So there is a significant expanded lungs and air retention. Okay, this is because all your airways are obstructed due to secretion, or they are, constricted. In this second picture, you have a mass in your mediastinum, which is compressing your trachea and your right main bronchus. So this can cause as well CO2 retention, and this can cause, if it's really severe, a type 2 hypercapnic respiratory failure. Okay, in this one on the right-hand side, you have a typical picture of a patient with spinal muscular atrophy. Okay, so severe muscle weakness and scoliosis. So these patients will have a type 2 hypercapnic, and if in some occasions they will have a type 1 also respiratory failure, but mostly they have type 2. So they are so weak sometimes that they will need non-invasive ventilation at home to support their breathing. Okay, and then on the last picture you can see a patient that has normal lungs, so no lung pathology, no cardiac pathology. But if someone has noticed this catheter here, this is a ventricular peritoneal shunt. So any patient with an acute neurologic condition, in this particular case, if you have an obstruction of the shunt, you can have impaired neurology, you can have signs of raised ACP, okay, and your respiratory drive will be poor. You will have low GCS, okay, and you will end up with type 2 respiratory failure. So what's the management of respiratory failure? So first of all, provide, so ABC. So go through your ABC, provide oxygen as needed, treat the underlying condition, get help from a senior member of your team, either an ITU consultant, a registrar, or an anesthetic registrar or consultant, in case the child needs airway protection or intubation. Okay. Then we have a form of you can start by using non-invasive ventilation, which is the easiest way to go, okay, unless the child is, in impending cardiac arrest and needs intubation right now. And you can use high flow nasal cannula. Remember, this is not a form of non-invasive ventilation. I just put it there for the presentation purposes. But remember, it's just a form of oxygen therapy. And then you can use CPAP or BiPAP. If the child is in impending respiratory failure or respiratory arrest, or definitely we need to protect the airway because the neurological condition is really poor, then we will need to go through mechanical ventilation. Okay, and we will use most probably non-conventional modes of ventilation, whether it's pressure or volume. We can use adjuvant of mechanical ventilation like nitric oxide. We can use magnesium sulfate, especially in patients with very poor oxygenation, because it relaxes the muscle of the pulmonary arteries. And you know that magnesium sulfate is also a very useful drug to use in severe asthma. Okay, because it relaxes as well the smooth muscle of the greater airways like bronchi. So if you have decided to use non-invasive ventilation, please make sure that you monitor your patient carefully. Okay, and if you have been for 1 or 2 hours on high flow nasal cannula or CPAP or BiPAP, and the child is not doing well, and by not doing well I mean the gases are still poor, the child is still tachypneic, the child is still tachycardic, there is no improvement since you have started your therapy, discuss it again with your senior member and consider that the child needs intubation and mechanical ventilation. So these are the general principles of when do we need to, intubate and mechanically ventilate a patient. I'm not going to go through all of them because you can have a look on the slides. I will send the slides to the members of the group, and you will have all the slides. So these are the devices that we use for non-invasive ventilation. So you have on the left-hand side the devices for high flow nasal cannula, and usually when you refer as a sick child with bronchiolitis, and we often tell you as a first choice, okay, start high flow nasal cannula at 2 liters per kilo. Okay, that's the usual starting point. Okay, some teams, they do have the facility to provide CPAP, nasal CPAP. The easiest way to do it is through this simple machine, which is called the bubble CPAP. Okay, some centers, they have other fancy devices like the Fabian, and these 2 devices can provide 2 levels of pressure, so IPAP and EPAP. If we go for non-invasive ventilation, okay, we should use a PIP no less than, I put 5 to 8 here, but take into account that you are using a form of non-invasive, so your airway is not going to be perfectly sealed, so you will have a lot of leaks. So you should use a proper degree of PIP to achieve what you want. So start with a decent PIB like 6 to 8, okay, and then you can monitor your patient from there. So what's better, high flow nasal cannula or non-invasive ventilation? That's the million-pound question. What's better, Apple or Android? Well, in my opinion, it depends on what's your patient looking like, okay, and what's your sometimes preferences, and what do you have available in your trust. So this is what happens, especially in bronchiolitis or in conditions of type 1 hypoxamic respiratory failure. So we talk about the closing capacity of or the closing volume, and we said that the small children or neonates, they do have a compensatory mechanisms to avoid this closing volume. What they do is they do this grunting movement. This is a reflex that they do to keep their airways open and to avoid the collapse of the small airways. Okay, they are basically providing an auto PIP. They are generating an auto PIP. When these children got sicker and they have a lot of secretions, these secretions can sometimes plaque and they can cause an obstruction into the airways, and this can cause atelectasis, regional atelectasis. And unless you apply a positive pressure to reopen these small airways, you will cause what we have talked about. You will cause atelectasis and you will cause BQ mismatch. And then if these atelectasis are big enough, then you will cause severe respiratory failure. So the way I see the non-invasive management of these particular patients is, yes, high flow nasal cannula is a good choice to begin with if they are not really sick, but essentially high flow nasal cannula is not going to treat the underlying condition. Okay, high flow nasal cannula is not going to provide you with a positive pressure that will reopen the lung and will reopen the small airways. And I will try and give you some evidence of that.
Hi, Frances. Just to
Hi.
let you know, we've only we're running a little bit short of time, but
Right.
Another 10 minutes is
I'll
absolutely
try.
fine.
Okay, I'll try to speed up. Right. So if you ask me what's the at least the minimal amount of CPAP that we need to apply, I said 6. It's not a random number. It's been studied. So 6 is the minimum amount of nasal CPAP that you should be applied to avoid the collapse of the small airways. Okay. And in this study, in this example, you will see 3 different graphs. In this one, the child is spontaneously ventilating. In this one, you are providing just conventional oxygen. And in this one, the child is on CPAP, okay? This is a measurement of pressure a long time. And the pressure is being monitored by a catheter in the esophagus. And basically, the esophageal pressure would have the same pressure as the pleura, and the same pressure as the pleural space. And you can see the swings here of the esophageal pressure up and down, from being very positive to being very negative. And by providing CPAP, what we are providing is an optimal recruitment of the airways, and these swings become less important. These swings, you need to understand these swings as you are overstretching your alveoli, and then you are collapsing your alveoli. Overstretching and collapsing, overstretching and collapsing. So this intermittent overstretching and collapsing is what causes inflammation into the membrane, and is what causes inflicted lung injury, whether it's inflicted by us iatrogenically or whether it's inflicted by the patient. Okay, and sometimes very sick children can have what we call self-inflicted lung injury, which is what is shown in this graph. Okay, it's the same. You will see 3 different graphs on oxygen, on high flow nasal cannula, on CPAP, and on 2 levels of pressure. And when you have lower levels of swinging is when you are using CPAP or BiPAP. Okay, if you let the patient breathe on their own with no pressure to support their breathing, they can go into self-inflicted lung injury. Okay, and they will become worse from a clinical point of view. So NIV has demonstrated to be effective on transport, and you have a lot of literature about that. And if someone is really interested in that, please feel free to contact me via email, and we can discuss further. Okay, and then in I think it was 2015, there was this study. It was a well-designed randomized clinical trial about what's better, high flow nasal cannula or nasal CPAP. And this study found that in the first hours of a patient coming to ED with acute respiratory distress, the difference between high flow nasal cannula and CPAP were not statistically significant, but when you were beyond 8 hours of admission, then is when high flow nasal cannula, when CPAP starts to become more significantly better. So, and it has a smaller rates of failure. Okay, so with that, I would say that for mild disease, yes, high flow nasal cannula is a good option. Okay, when you have moderate to severe disease, high flow nasal cannula should be really considered. Maybe you should consider going into CPAP earlier rather than late. Okay, to avoid NIV failure. There are some contraindications for NIV. Okay, and this is the list of contraindications. I will try to speed up this. You will have these slides, and you can look at the contraindications of NIV. And then, as I said, high flow nasal cannula is a good tool for mild disease, and is a subjectively better tolerated tool compared to CPAP. But again, when you have severe disease like severe ARDS or severe acute lung injury, sometimes it delays intubation. And when you delay intubation in severe ARDS or severe acute lung injury, studies have demonstrated that the mortality can go up to 50 or 60%. So just quickly, how do we manage type 2 hypercapnic respiratory failure? How do we manage Wheezers? Severe asthma. So these are the British Thoracic Society management for asthma. Okay, and what I want to say here is it's okay to use back-to-back NEPs. I'm not against that. What I'm most probably against is the use of IV salbutamol and IV aminophylline. So if you are thinking to give IV aminophylline or IV salbutamol either as an infusion or as a bolus, please before call an ITU service or call a pediatric retrieval service, okay? And we will provide a bit of advice around that. Or, I mean, if you are reaching the point to think, oh, he might need salbutamol infusion or salbutamol bolus, this is a candidate to refer to a transport team, okay? And this is a candidate that might might end up in an ITU, okay? So how do we ventilate these children? I would say, if possible, we try not to intubate these type of patients, especially asthmatics. Okay, as soon as you intubate, they become like a nightmare. It's very difficult to ventilate. You have to use very high peak pressures to achieve the goals that you want. Okay, and it's very scary to have children on a ventilator having peak pressures of 45 centimeters of water or 50 centimeters of water. So when I'm in transport, I usually carry a large ApoCat with me because it's a high risk of having a pneumothorax. Okay, they have to be very well sedated and sometimes muscle relaxed. If not, they become really difficult. Okay, and I know it says don't manually decompress the chest. There is a risk of cardiac arrest. Okay, but sometimes they have so high CO2 retention that we need to disconnect them from mechanical ventilation and manually decompress the chest to allow them to eliminate all the CO2. Okay. And as it says here, is a very high risk intubation. So it needs to be done by the most senior or the most expert person in the trust at that moment. Okay. And these are the drugs that we normally advise for intubation. So ketamine is the drug of choice because it has a effect of, it reduces the muscle tone of the smooth muscle in the bronchi. So it's a very good drug for that. And then Rocuronium. So we advise for a rapid sequence induction with these two agents, okay? And have fluid boluses next to you, okay? Because as soon as you remove the respiratory drive of these children, they have a significant component of dynamic hyperinflation and air trapping, okay? So they have a lot of positive pressure inside the chest. Their venous return is compromised, and as soon as you give sedation to these children, their blood pressure can fall down. So be ready to give fluid boluses, okay? By the time you are inducing them. Right, and yeah, what I wanted to show you is the difference between the nebulized salbutamol and the IV salbutamol. And from the graphs, you can see that when you are using inhale or nebulized salbutamol, the peak effect of bronchodilation stays longer, okay? And the effect on heart rate, okay, is lower compared to the IV salbutamol. So the IV salbutamol has a very quick peak effect, and it stays for a very small amount of time. And on the other hand, the side effects, they are much greater. So they have a huge impact on the heart rate. And that's why some children with asthma treated with severe subsequent boluses of salbutamol IV or in a salbutamol infusion, they become really tachycardic and they develop lactic acidosis. This most of the times is due because we are overdoing, okay? We are giving too much bronchodilators, okay? So please, if you give a salbutamol IV dose, monitor the response. And if there is no response, okay, don't give it again. Okay, we might need to tube the child. It's fine. Maybe we should start some NIV, or maybe we should give some IV magnesium sulfate. But if there is no response to IV salbutamol or IV aminophylline, please don't give it more, because it can cause more problems. Okay, and if we need to, if you think, oh, he might need more, please discuss it with an intensive care team and a transport team. Okay, I'm gonna skip that.
Dr. Torres, I was hoping we might have a little bit of time for some questions.
Yeah, it's 5 minutes. I think
5
I have
minutes? Yeah, okay.
two more slides or 3 more slides.
Sure.
That's it, no more. Okay. So as you can see from this study, most of the conditions that you will face in an A&E department, they have very low rates of NIV failure. So yes, NIV is a very good choice from the beginning, okay? But when you see a child with severe acute lung injury, but because you can see the X-ray and the X-ray looks very bad, and or he's requiring a lot of oxygen, he's in a very poor condition, you can see that the NIV failure rate of ARDS and severe acute lung injury is very high. It's 50%. Okay, so there are groups that says that sometimes it's better to intubate earlier rather than consider NIV and wait for the child to fail. So if the child has severe ARDS or severe acute lung injury, and I will talk how do we say that this is severe or not, it's better to consider, okay, we should probably tube the child in order to have a better outcome. It sounds a bit weird or controversial, but the studies have demonstrated that if we delay intubation in these patients, the mortality is higher. So this is the definition of pediatric ARDS, okay? And you will have the exclusion criteria and how do we define ARDS according to these two ratios, the Puffy ratio and the oxygenation index. So the Puffy ratio is the relation between the arterial oxygen pressure and your FiO2, and this is the formula to calculate it. Okay, so we said severe ARDS when the Puffy ratio is below 200. Okay, when you are in non-invasive ventilation, or you don't have an arterial gas, we have what we call the SAFI ratio. So the ratio between your oxygen saturation and your FiO2, okay? And we said that there is a severe ARDS or severe acute lung injury when the SAFI ratio is below 200, 150, okay? However, these two ratios, they don't take into account your mean airway pressure. How much are you, how much pressure do you need to keep this child well oxygenated? So there is another ratio or another data that we use, which is the Oxygenation Index, okay? And the formula is here. And in this formula, you can see that we are taking into account how much pressure we are providing, okay? And when we have an Oxygenation Index beyond 10, 15, we say that the child has severe ARDS. We need to consider other forms of medical management, okay? So we should probably use non-conventional modes, which we can do in pediatrics, like high frequency oscillatory ventilation. We can do prone positioning, or we can even refer children for ECMO, okay? So this is a kind of algorithm that the Society of Critical Care in Spain uses to go through which patients do we need to put first in mechanical ventilation, and which ones we can, wait and see how they do in non-invasive. Okay, and this algorithm uses the SAFI ratio. Okay, but again, if we have a PAFI ratio below 200, 150, these patients probably need to be intubated sooner rather than later, okay, to avoid increased rates of mortality. All right. And then this is my last one, okay? So as you can see here, the lower the PAFI ratio, the worse the condition of the child is, and the lower the PAFI ratio, the more aggressive we need to be in our treatment, okay? So we start by, non-invasive. If non-invasive is not working and we still have low PAFI ratios, despite all our management, we probably will need to intubate. We will need to use what we call lung protective ventilation, so higher frequencies, low tidal volume, using optimal PIP. We do sometimes need to oscillate those patients, okay, as a form of non-conventional ventilations. We sometimes need to prone these patients, okay. We use nitric oxide as well. And if all this medical management is not working, then the last point is refer those children for ECMO, okay. And this is my last slide. I hope you have enough about ventilation. I've had to speed up a little bit the last slide, but I hope everything was clear, and I'm open for questions.
Thank you so much. Such an incredible and very comprehensive teaching. I think we can run a little bit over. There's a couple of questions, if that's okay, on the chat. One was asking about how soon after the first dose of Mag-Sulf can we give a second? So
there is no specific frequency to give magnesium sulfate doses. The problem with magnesium sulfate is that it can cause hypotension. So if you are about to give magnesium sulfate IV, make sure that the blood pressure is good enough, okay, because it can drop your blood pressure. So we always advise to give it over an hour. So definitely more than 30 minutes infusion, okay, and monitor the response, okay. Usually we don't tend to give doses of magnesium sulfate more than every 4 hours or so, okay. It has if it has a good response, the response stays for a period of like 2 or 3 hours, okay.
Perfect. Thank you so much. I think it's probably time that we move on to the next talk, but thank you again for such an excellent talk.